Assalamu alaikum everyone, welcome to OBG with Sadia Idrees. I am Dr. Sadia Naz, consultant obstetrician and gynecologist, and today we are going to discuss an important, very high obstetric topic, unstable lie in pregnancy, its inpatient management and timing of birth. This is an extremely important topic not only from day-to-day clinical practice but also for MRCOG, MRCPI, FCPS MS and IMM examination. An unstable lie may appear harmless at first, but if it's not recognized and managed appropriately, it can rapidly become an obstetric emergency, placing both the mother and the baby at significant risk. So, in this lecture, we'll cover how to diagnose unstable lie, when to admit, inpatient management, and timing and mode of delivery. So, without wasting any time, scenario: imagine you're on a labor ward duty. A 37 weeks multiparous woman comes to the antenatal clinic. Her ultrasound shows transverse lie. 2 days later, on repeat examination, the baby has spontaneously turned into cephalic presentation. Everything seems reassuring, but 1 week later, during another routine review, the fetal lie has changed again, this time to an oblique lie. Now, pause for a moment and think like an obstetrician. What exactly is happening? Should this woman be admitted? Can safely she go home? Should labor be induced? Or she is likely to require cesarean section? These are the questions every obstetrician must answer correctly, because an unstable lie can suddenly lead to cord prolapse, fetal compromise, and obstetric emergency if not dealt correctly. So, before we dive into the topic, let's understand what you will gain from this lecture. By the end of the session, you will be able to confidently define unstable lie, identify the major risk factor, understand and learn the maternal and fetal complication with special emphasis on the single most important complication, umbilical cord prolapse. Next, we will discuss when hospital admission is recommended, which patient requires inpatient management. We'll then cover the timing and mode of delivery, helping you decide when to await spontaneous correction, when induction is appropriate, and when cesarean section is the safest option. Finally, I'll share the high-yield MRCOG, MRCPI, FCPS, MS, and IMM examples. The key point examiners frequently ask and every obstetrician should remember. So, let's begin with the most fundamental question. What exactly is an unstable lie? An unstable lie is a fetal lie that continues to change rapidly after 36 to 37 weeks of gestation instead of remaining in a stable longitudinal position. Normally, by this stage of pregnancy, the fetus settles into a definitive presentation, most commonly cephalic and less commonly breech. This stable position allows us to plan the safest mode of delivery. However, in an unstable lie, the fetus fails to maintain one fixed position. It may change from cephalic to breech, then to transverse, and later to an oblique lie over a short period of time. This repeated chain of fetal lie is what defines an unstable lie. And when the fetus change position after 36-37 weeks, so immediately think of an unstable lie. Now that we know what an unstable lie is, the next question is, why does it happen? In most cases, an unstable lie is multifactorial. In other words, more than one contributing factor may be present. First is multiparity and grand multiparity. Another important cause is polyhydramnios. Excess amniotic fluid provides additional space, making it easier for the fetus to change position rapidly. Placenta previa, well recognized risk factor. Women with uterine anomalies such as bicornuate uterus or septate uterus. Multiple pregnancy, an important risk factor, particularly after delivery of the first twin. Finally, abdominal wall laxity and preterm labor may also contribute to preventing the fetus from settling into stable longitudinal position. So, when we identify the risk factor, the next step is assessment. Before deciding on any management plan, every woman with a suspected unstable lie should undergo systemic maternal and fetal assessment. Let's discuss step by step. First, confirm the fetal lie by abdominal palpation using the Leport's maneuver. Helps determine whether the fetus is cephalic, breech, transverse, or oblique. Second, perform an ultrasound examination. Ultrasound confirms the fetal presentation, placenta location, amniotic fluid volume. Helps identify any underlying causes such as placenta previa, anomalies, or fetal abnormalities. Third, it is essential to exclude placenta previa, as a low-lying placenta may prevent engagement of the presenting part. And next, assess fetal well-being by either cardiotocography, or fetal sonicate. At the same time, assess whether the woman is in labor or whether there has been spontaneous rupture of membrane. Now, how unstable lie is diagnosed? As I have discussed by clinical examination and ultrasound assessment, fetal lie should be assessed by abdominal palpation using the Leport's maneuver. And as you know, that repeated cheer after 36-37 weeks is a hallmark of unstable lie. However, clinical examination alone is not sufficient. Diagnosis should always be confirmed by ultrasound, where it can accurately identifies the fetal presentation, fetal lie, placental location, amniotic fluid volume, and fetal anomalies. So, a common examination question is, why is ultrasound important and stable lie? The answer is ultrasound confirms both the fetal lie and the underlying cause, making essential investigation before planning management. Now, the next question, when should the patient be admitted? According to RCOG Green Top Guideline, women with an unstable lie should be offered hospital admission from 37 weeks of gestation. Why 37 weeks? Because from this stage onwards, labor or spontaneous rupture of membrane can occur anytime. If the fetus is still in a transverse oblique lie, there is significant risk of umbilical cord prolapse, which is an obstetric emergency. This woman includes a high risk of preterm labor if and a previous history of cord prolapse, polyhydramnios, placenta previa, multiple pregnancy, or the significant obstetric complication. The purpose of planned admission is not simply to keep the patient in hospital, it allows close maternal and fetal monitoring, early recognition of retained fetal lie. Am I clear? So now the patient has been admitted. The next step is inpatient management. The primary goal of inpatient care is close maternal and fetal surveillance to reduce the risk of cord prolapse and ensure immediate intervention if labor starts or the membrane rupture. Let's go through the key components. First, assess the fetal lie daily. Regular abdominal examination helps identify whether the fetus remains cephalic or changes back to a transverse or oblique lie. Second, after every abdominal examination, auscultate the fetal heart to confirm the fetal well-being. If the fetal heart lie is uncertain, perform a bedside ultrasound. Maternal monitoring can also be done by maternal early warning score. Every admitted patient should undergo VT risk assessment. If indicated, provide compression stocking and regular review by both midwife and the obstetrician. Never estimate the importance of patient education. If the lie becomes cephalic, spontaneous turn into cephalic and head down position, does that mean the problem has been solved? Not necessarily. The first step is to confirm the cephalic presentation with ultrasound. Clinical examination is helpful, but ultrasound provides the most accurate confirmation. The fetus should remain in a stable cephalic position for at least 24 to 48 hours because the fetus may still rotate back into transverse oblique lie. Once the cephalic lie remains stable, management should be individualized. If there are no maternal fetal complications and labor has not started, the woman may be managed conservatively and await spontaneous labor. However, if the cephalic presentation remains stable and there is an obstetric indication, she may be discharged home with clear safety advices and instruction to return immediately if labor begins. What if labor starts or membrane rupture? If this condition occurs, this is the most important slide of the entire lecture because it describes an obstetric emergency. Imagine a woman in an unstable lie with painful regular contraction and membranes rupture spontaneously. What should be immediate response? This may be raise concern of umbilical cord prolapse. Why it is dangerous? Because umbilical cord can slip below the presenting part. The cord may become compressed between the fetus and the maternal pelvis, leading to acute fetal hypoxia, and if not managed, promptly fetal death. It is an obstetric emergency. The first step is to start continuous CTG to assess the fetal well-being. Definitive management is emergency cesarean section. Do not wait for spontaneous correction of the lie. Do not attempt induction of the labor. And in most cases, vaginal delivery is not indicated. The patient priority, baby safety is the immediate priority. Am I clear? So, as we come to the end of this lecture, the key take home messages: number one, women with an unstable lie offer admission from 37 weeks. Number two, never rely on clinical examination. Ultrasound confirms the fetal lie and helps identify the underlying cause. Number three, most important complication umbilical cord prolapse. Number four, when the labor starts, continuous CTG should be commenced. Number five, a transverse or oblique lie during labor, obstetric emergency. Safest management, emergency cesarean section. And finally, if the fetus turns cephalic, confirm it with the ultrasound and ensure the lie remains stable for 24 to 48 hours. I hope this lecture has made the management of unstable life simple. If you found this lecture helpful, like, share, subscribe. OBG with Sadia Idrees.